Hi, everyone. Welcome to our afternoon breakout. I'm going to introduce our incredible, wonderful, fantabulous speaker. This is Kasey Edwards. She's a specialized doula and is going to be talking about harm reduction strategies. I want to remind everybody that even though this is a small space, which is awesome, we're still going to use the microphone so that way the recording picks it up. And just for general accessibility reasons, we don't want to assume, so we're just going to use the mic. And you're going to help me remember that. So everybody, welcome Kasey Edwards.
Okay, just before we get started, am I allowed to take this off?
You can.
And move?
Yes, don't go too rogue.
Okay.
Don't leave the stage.
Okay, I'm gonna try.
You can't take it off.
So, yeah, not yet. I'm gonna see if I can do this without getting too anxious, but something about a podium always kind of feels really strange to me, especially when I'm like, gonna headbutt this. I should have done this before. Is that still okay? Okay. So hello, you guys. I'm just here to kind of talk through harm reduction strategies for the people in the perinatal phase of their life. I hate slides, and I'm going to do the best I can to stay on topic, but some of the slides are pretty basic, right? Because we have people from all walks in here today. Well, I don't know about in here, but in this general space, we have people from all walks. So I'm going to kind of go through the broad overview while touching on things that I have found are really important. So this is my financial disclosure. I don't own stock in anything. I'm not that fancy. Words. So I'm a specialized doula, peer support specialist, and a certified addiction counselor. I'm also a certified recovery. There's all sorts of letters for people that are peers and people who have lived experience and do this work. Historically, I helped build Project Nurture with Dr. Josh Reagan back in 2015, 2014, something like that, over at Providence. And I did that work just up until May of last year. I hate these bio things. I do a lot of contract work. I have worked with various states building programs like Project Nurture or just frameworks within existing programs for doulas with lived experience to kind of be a part of the broader picture. So our objectives today are to understand the principles and I hate slides. Are to understand the principles and the importance of harm reduction in prenatal care, and to learn effective strategies for reducing stigma and barriers to care. A big part of that for me is just the overview of what those barriers are and kind of putting into perspective what the world looks like for vulnerable pregnant people. Am I going too fast? Okay. So pregnant people use drugs. It's not up here, but I'm pretty sure that everyone in this room, or most of you, have done drugs at some point in your life, whatever that might look like. It is not an abnormal experience. The difference for a lot of us is that poverty and bad social systems and everything else kind of send us down the wrong road when we find that automatic solution. So substance use during pregnancy occurs across all demographics. There is no one who is immune to the risk. I have worked with people who come from pretty affluent families, and I have worked with people who have been outside since they were 12. It's just this disease I hate that. Substance use affects everybody. So approximately 5 to 6% of pregnant people use substances. Rates of neonatal abstinence syndrome have increased by over 300% since 2000. That feels weird. Stigma often prevents individuals from seeking care. We all know this. This is not an uncommon thing. We're seeing it in the media. We're getting a lot of attention. Not we specifically, but pregnant people who use drugs are getting a lot of attention, negative and positive, from various places. So what is perinatal harm reduction? So perinatal harm reduction is essentially a public health framework to reduce trauma, to reduce stigma, to reduce people from losing their kids and the forced alienation between parents and their children. I'm working really hard to change my language from mothers, because it's not just mothers anymore, right? Like, we have all sorts of people having babies and we need to honor them. So perinatal harm reduction really focuses, I am right under a heater vent. Okay. Yeah, so perinatal harm reduction focuses on non-judgmental, trauma-informed care to meet individuals where they are. What that really looks like is not caring what somebody's up to. So for me, one of the first things that I ever say to somebody when I'm meeting them, whatever stage they're in, is that I don't care what they do. Like, I really don't, I have no skin in the game about what they do, but I do care about that they get what they want. And that really opens up the framework for them to make their choices, them to make their mistakes, them to do whatever it is that they feel like they need to do, and to know that they have a support person along the way. I've found that many of us have bias, right? Or we think we know what people need to do. There's this golden thread of how people keep their babies, how people get clean, how people navigate different substance use disorders, right? Like, we all have a framework, sometimes imposed upon us by our organizations, by our, what's the word? I don't know. The metrics in which we serve, right? Most organizations have a goal, right? Like, outcomes. Like, this is what they're trying to see happen. And with perinatal harm reduction, that shouldn't be the goal, right? The goal with perinatal harm reduction is to support pregnant people, whatever that looks like for them. And we don't get to decide what that is. So again, empowering pregnant individuals through safer practices and improving maternal and neonatal outcomes. I'm probably gonna run out of time because I keep elaborating. So I'm just gonna skip that one because I'm gonna talk about it some more. So key principles of, is this still okay?
I think it should be closer. That would be, yeah. The
Okay.
closer, the better.
I'm just sweating. So.
You can take it off. You can take it off the stand.
No. So key principles of harm reduction in pregnancy, I just talked a little bit about them. So non-judgmental, person-centered care. Again, we can care. We can't impose our beliefs onto them about what their life needs to look like to be successful parents or to not be successful parents, right? Like, whatever they want to do, we need to be able to honor that regardless of how we feel about it. So again, emphasis on safer use strategies and managed withdrawal. So that is objectively, so as a doula, I don't know how many of you guys are familiar with doulas, but our job as doulas is to provide all the information necessary for people to make their own choices. So no bias, right? Like, I can't go in there and say, like, I really hate circumcision, these are the reasons why, here's all these resources why it's bad, right? Like, that's not the thing. We're supposed to bring all the information to the table and support them in navigating the choices that they make, right? Like, whatever those are. No bias, no opinions, not for me. It's no different with harm reduction. So that relates to sharing all the information about safer use practices. So I'm somebody in long-term recovery. I spent my last stint in medical detox, because I have seizures, which is super fun when I have withdrawal, was back in 2011. My son was born in 2009, and I had to navigate all of this. But nobody was explaining to me when I was pregnant with my son what I was doing. I just thought I was killing my baby, and I was a terrible person, and I didn't deserve to live, right? That was not conducive to anything. And when we do this work, we have the opportunity to give people all of the information. So for me, that often looks like asking people, do you want to know? Like, what details do you want? They always want to know, but what details do they want to know about, like, methamphetamine use in pregnancy, right? Like, and most of the time, they'll be like, okay, I don't want the ugly details, just tell me what, and then we can start exploring safer uses of care, or safer things to do, or alternatives, or what have you, right? But also making sure that us as harm reductionists working with the pregnant population, we know the truth. And we have explored all of the resources. We have talked to doctors and medical professionals, and we have fact-checked them too. I love all of you people. I love all of us who do this work, right? Like, it's so important that we do this work, but we all have different information. And so it's important that as harm reductionists, we're looking at that and we're learning how to share that information with the people that we serve in a way that's tolerable, right? Like, so a bunch of doctors told me I was just gonna kill my baby, right? And that's not real. Like, I could have had a placental abruption. They could have explained that to me and explained to me what that looks like, right? Like, my baby could have had withdrawal stuff. Fortunately, I got arrested. Didn't think it was great at the time, but I got arrested when I was pregnant. But we don't typically share that with people because it's scary and hard. And from the trauma-informed lens, we don't want to do harm, right? So sometimes doctors, nurses, whatever, be like, you're hurting your baby. Because it's easier to say you're hurting your baby than these are the risks, and then maybe giving them permission to use differently. So reducing stigma and discrimination, same thing. We got to speak up for our people. I hate standing. I'm normally like all over and like doing a thing, sitting down. So reducing stigma and discrimination, we talked a lot about that today. I don't think I need to go super deep into it, but we have to be willing to call people out. So like on labor and delivery, so like I was on labor and delivery and in the community and in a family medicine clinic for a really long time. And I had to get comfortable being that guy. So being somebody with lived experience coming in from a pretty extensive, a pretty terrible background, I'm just gonna say that much, that set me apart from the medical professionals and the people who had the money for school and like all of that. I had to get comfortable speaking up. And what really made a difference there was when the people that I spoke up to, we had a beautiful conversation utilizing motivational interviewing and all of these other therapeutic tactics that I have absorbed over my career. Those people then, that I was able to make an impact on, went on to their friends and their fellows and their colleagues and whatever, and were able to share that information and ask them, where's that belief come from, right? Like that was a big thing for me. It's like, where's that belief come from when people are just talking around the coffee pot or whatever? And then addressing social determinants of health. Everyone knows what social determinants of health are? Yeah? Okay. So barriers to care, we all know what these are. We've been talking about it all day. Stigma, bias, discrimination, disruption of family unit, being undocumented, intimate partner violence. That one was a huge thing for me in my own personal life and in the people that I serve. There are so many people that were not allowed to receive prenatal care because their partner was afraid, right? That under the guise of being afraid of losing the baby, they were afraid of losing the person, right? And I don't want to assume, but these are things that people have actually told me because I'm a little bit untraditional in that I will build relationships with the whole family, regardless of what partner has done or has not done. Lack of transportation, we know this, right? The buses are ridiculous. You have 2 kids on your hip, you're trying to go to the VHS office, it's impossible. No phone, no data, no internet, don't have supplies, unsafe housing, trauma, lack of childcare. Methadone dosing is super hard to engage with. I don't know how many times I stood outside the methadone clinic 5 minutes late for intake. Like, it was like months of my life. Every day I'd be like trying to get to the methadone clinic and I was 5 minutes too late for intake. Right, so like it's not as easy to engage with these services as we all want to believe. Granted, this was 2007, 2008, 2009, whatever. It hasn't changed. It hasn't changed a whole lot, right? Things have got a tiny bit more accessible, but you have to know the right people. You have to have a phone. You have to be working with somebody already. Well, how do you do that? So success stories and case studies. I'm not going to go super deep into this. Are you guys familiar with Project Nurture? Okay, so in our first couple of years of Project Nurture, we were able to increase doctor's visits, that's how I'm gonna say that, 40%, right? That's huge. It doesn't seem like huge because like 100%, 50%, whatever, but 40% is massive. Rates of neonatal abstinence syndrome decreased by 25% among program participants compared to standard care. And like comparing to standard care means comparing to other people that were getting prenatal care. So like in perspective, these numbers are compared to other people that were receiving prenatal care, and that number does not control for the people who were on methadone and doing well. And still, neonatal NOWs, no, not NOWs, neonatal opiate withdrawal. I don't know. The word we're using today isn't always relative, right? So like sometimes babies even have withdrawal from Subutex or Suboxone. It's a lot less than traditional use. Fentanyl's crazy, but that's an insane number. And that's just because they had wraparound support. So they had peers, or they had doulas, or they had both. They had a drug and alcohol counselor. They had a case manager that was helping them access all those resources that are untenable. And they had doctors that care and were constantly educating and informing themselves. Did you raise your hand or fix your glasses?
Fix my glasses.
So over 85% of program participants reported feeling supported and less stigmatized. Now, huge number, but what I think is the cooler thing that's not documented in a study is by the time I was leaving Project Nurture last year, even after we had a whole bunch of our nurses recirculate and got a bunch of new ones, I think I had 2 people in a year tell me that they felt judged with our labor and delivery staff and everything else. And that's because Project Nurture as a clinic, like we have our own little clinic, expanded into the hospital system, right? They now have work groups and everything else across the board to navigate this. And when I started there, that was not the case. When I started there, I had to justify my existence every day because I had a contractor badge. And when I started Project Nurture, you guys, I had a headband shaved into my head, like shaved belly bangs, like I wore combat boots and cutoffs every day. I didn't know. I was just living my life, trying to be relatable, trying to be myself. But still, right, it worked, right? Because I looked like the people that I was trying to serve. Or I looked worse than them, which automatically they trust you a lot more. So that's just what it is, right? Like intentionally swearing a lot. So why harm reduction? We know traditional punitive approaches deter people from seeking care. We know non-judgmental support leads to better health outcomes. We know that empowering individuals with evidence-based strategies reduces risk. Now, we know all of that, but we're not doing it, right? We think some places we think we're doing it, some places we're doing it pretty well, but we can do better. But the fear around, and this is not what my topic's about, so I'm just gonna make it quick. The fear around not being trauma-informed keeps a lot of our people not informed. And so I just ask anybody in this space who's working with pregnant people to ask your participants or ask your patient or ask your client, what do you want to know? Like, I hear you're afraid of X, Y, and Z. Like, what details do you want? Like, where do you want to see the answer, right? And sometimes they don't want to know. Very rarely, they don't want to know. But that's an opportunity for us to tell them they're not going to kill their baby. And these are the things that could happen, and these are the things we can do about it, right? Objectively, still not telling them what to do, still not making anything about me or my feelings or my story, right? Because I do have a story. It's not about me or what I did to get better and change my world. It's about them, right? So, neonatal abstinence syndrome, are we all familiar with this? Anybody who works with babies? Is that it?
No.
No.
Anybody work with babies? I can work with babies. Is that what you said?
Yeah.
Yeah.
So neonatal abstinence syndrome care approaches, right? So neonatal abstinence syndrome, there's a better word for it now. I was not thinking about it when I wrote this up. But so symptoms, irritability, feeding difficulties, tremors, right? And so like we're not talking about a baby that like has chills or a baby who doesn't like has a tongue tie or some other feeding complication. We're talking about a baby that's tensed up, right? Or talking about a baby that like flails, right? We're talking about a baby that's unconsolable. I can't remember the exact number. Does anybody know the exact number of minutes that a baby is supposed to cry before you decide that they're unconsolable? 10. So 10 minutes. So that's not holding an upset baby for an hour. Oh, no. For a minute and not being able to soothe them. That is putting 10 minutes in trying all the things that we know. So swaddling, feeding, this thing, it's so weird. But this thing, I don't know. It's just magic. Like I have roomed in with so many patients for so many hours just because like this is magic and I have my upper body strength right now. I didn't push out a baby. So non-pharmacologic interventions, skin to skin, and breastfeeding when appropriate. Appropriate in quotations because I have feelings about it, but I have bias about it. I feel like breastfeeding is always appropriate unless someone is like actively doing fentanyl and not utilizing harm reduction tactics. So that, basically breastfeeding when appropriate is when the medical establishment and DHS says it's okay. And that's something we can fight against. There's lots of data, there's lots of studies, there's all sorts of things. If anybody's curious about that, hit me up, send me an email, I will load you up with information. Medication management when necessary. So in this slide, that's about maybe giving the baby something extra, right? So morphine. We don't have, I am not a doctor. At Providence, we had a lot of success with not starting babies on a regimen. So that kind of standard of care, it's been a while since I've been on labor and delivery, so I'm sure things have changed. But standard of care was, baby was not okay, morphine helped, and then they would start baby on a titration schedule, right? Like whatever to keep baby okay. Baby doesn't always, or in my experience, anecdotally, we saw a lot of success with babies just getting like a dose and getting over that one moment in time that was unmanageable for them. So when necessary means what the doctors say, everyone else. But if we arm ourselves, I don't know how many of you guys are doctors and nurses. As a doula, arming myself with all the information helps. It helps. Not because I'm going to get in that doctor's face and tell him all the things that I feel about what he's doing, but because I can say, hey man, I read this thing. You want to read this thing? Like, whatever. Just trying to keep it super casual and gentle or whatever, because the power over dynamic is real. The power over dynamic is super real. So family-centered care, postnatal support for better outcomes. We know babies with their parents are better, right? Like skin to skin, smelling your mother, all of those pieces of that, we know that that's better. So parental involvement is key, right? We all know that babies do better when they're not alone in a NICU bed with a gavage tube forever, right? So supporting all of that is absolutely, I thought this was a mouse, is absolutely in our client's best interest. It is harm reduction, making sure that that parent, regardless of what's going on with that parent. Now, there are definitely times when somebody is maybe even a danger to themselves in whatever situation, and we gotta talk about that and work with that patient or that participant, talking about all of the pieces and making sure that they don't embody all of their fear and all of their self-loathing and never come back to the NICU, right? Security gets involved. People get involved when things are disruptive, when things don't follow the status quo. And so supporting our people through that and making sure that they know what's really going on and that they can come back, making a plan with them, the medical establishment, whatever, to support them coming back. I don't know how many parents have just ran and hated themselves, and then I've seen them resurface years later, not okay, because they lost that baby, they feel like they abandoned their baby and everything else because some security guard was an asshole, right? And like we have an opportunity to be a barrier between security or police interaction by just having relationship with that participant. So safety planning and preparing pregnant people. We just talked a little bit about that. So what that has meant in my experience, sometimes I haven't been able to meet my parents until they're having their baby right now. But that doesn't mean that I wasn't able to kind of talk to them about what needed to happen next. Like I've learned how to not stutter, but it still happens. So, thanks guys. So working with people to figure out what's gonna happen, like what the likely outcomes are, is always the solution. So sometimes I have gotten to meet with people and figure out, okay, your housing situation is shit. Sorry, language, I know. Your housing situation sucks. This sucks, that sucks. You're actively using, this partner is terrible, all these people around you are trash, right? And like, I'm not saying that. I am reflective listening, we're talking about it in a humane way, and helping them work on those barriers, right? So helping them get through whatever it is that's gonna hold them back from taking that baby home. A lot of times that means inpatient treatment because poverty, right? Like we live in a super ableist society. Just deciding you're not gonna be homeless anymore isn't an option, right? So figuring out with that person what works for them. Sometimes nothing works for them. Sometimes going to treatment isn't an option because it is not the trauma-informed thing for their experience. They have a dog, or they have this, or they have that. They're afraid they're going to lose X, Y, and Z. All valid. As a homeless person, or as a previously houseless person who has lost everything that I own, including my identification documents, time and time again, it's valid. But we can often help solve those problems, right? I have a file cabinet that I used to keep people's important stuff in. But so strategies and resources, that doesn't always mean we're the solution. Sometimes that means we connect them with someone else. Sometimes that means that I answer the phone because I have a phone and I track them down while that person's on the phone. Or that I try and be near them when this is happening, right? And that's just me being in the community and in the hospital and everything else. Like, that is a privilege that I've had in this work. But that doesn't mean that the social worker at your hospital can't be navigating a resource or helping somebody navigate something. And a lot of our social workers do that. But the conversation with people to figure out what it is they need or are willing to do or want to do to fix those problems often doesn't happen in a trauma-informed way with somebody that they just met that is fancy business cash and can't say the F word. So safety planning and preparing pregnant people is not just about making a plan. It's not about us making a plan for them. It's about us having prepared them for what's likely going to happen, right? So like, even if my person has no risk factors, right? They're going home to mom's there all the time, and mom's great, very rare, but mom's great. All of the things are in place for them to be able to go home. That still means we're explaining to them all of the different everything, right? So like, this is what could happen if this happens, and X, Y, and Z. So that they're fully informed, and then they can make decisions moving forward based on that information. Does all of this make sense? Landing okay? So, I have another slide. So, safety planning. It's talking about their environment, everything else around them, the people around them, child welfare. It's preparing them for what child welfare wants to see, right? Because that's something we know, right? Like, that's not an arguable thing. Somebody's supervisor is going to have some feelings about something at some point. So preparing them for all of those possible things so they know the steps that we have to take or the things not to do to get them what they want. So use and recovery. That is not pushing somebody towards any particular angle of recovery. That is not saying abstinence is what you have to do or whatever bias you might have about recovery, right? Like, my recovery doesn't look like everybody else's. I did the 12-step thing, multiple meetings a day for the first couple of years of my life. Then I got diagnosed with autism and everything else, and I learned I have other needs. And I have been able to cater to that, right? That means everyone's recovery is their own. Most people that I've served in the last 3 years still smoke pot. And that is okay. That is absolutely okay, right? Like, whatever people need for their recovery, just like every one of you, have different needs to be okay, different needs to enjoy yourselves, different needs to live your life. And we need to afford that to our people. But, and that's the big but, there's a lot of resources that don't accommodate. So supporting people through that means making sure they understand that you don't care and helping them navigate those resources in those situations. Like, just normalizing everything. There's a lot of other recovery communities out there, and more are popping up every day because for me, the most important thing for my recovery was community. So not being alone, not going home to the trap house or my dad's meth lab or what have you, right? Like, that was what got me where I'm at, and what kept me there is finding my people. Now, you don't find your people on 2nd and Burnside. You don't. It's just a thing. You might find your people and then realize later, like, both do different, and then, you know what I mean? But changing people's surroundings, so helping them prepare for not being alone. Now, if your person has access to a peer, that is a huge first step, because then they're not alone, right? Depending on that person's hours and their organizational expectations. But for me, I stupidly made myself on call all the time. Like, as a doula, makes sense. But as a peer and a counselor and everything else, oh my gosh. I don't do direct service anymore. But all of those things, right? So access to resources, again, social workers out there, nurses, like you guys can know things. It's not everyone's job to know all the things and to be like, hey, I heard about this particular housing situation or this group living thing. It's not your guys' job. It's probably not in your description, but it doesn't mean you can't do it. It doesn't mean you can't know. You can subscribe to some email list somewhere, maybe read it when your inbox gets up to 220, you know, but you might know something at that point that you could then lend a hand to. And that is the most trauma-informed thing you guys can do. Like, as medical professionals, it's just like know a thing, be like, hey, this thing might help, or whatever. Like, that is building relationship, and that is 100% the solution to fixing all of our healthcare challenges. Being able to build relationship and rapport with your people without bias. Natural supports. We talked about this. Friends, not shitty aunts, you know what I mean? Like, the amount of, bias is real and alive everywhere. And when there's baggage, it is an ugly, ugly thing. But supporting people and finding their natural supports, like I was just talking about, those recovery groups. Like, or not recovery groups. Like, you like knitting, you want to learn, like whatever. Like finding people somewhere to be in community with other people that aren't a detriment. And we don't get to decide what a detriment is. It's really hard. It's very, very hard to not say you need to stay away from this guy, but making sure that you're having those conversations and you're having, like, you're really utilizing motivational interviewing. Do you guys know what motivational interviewing is, everybody? Generally? So utilizing that to ask the questions, let them find their answers, and then ask more questions. Because these are deep thoughts, right? And trauma brain doesn't allow for a whole lot of deep thought that is objective. And we can support people in those conversations. So parenting and harm reduction, providing non-stigmatizing resources for parents, navigating substance use, recovery. So we just talked about that. Parenting while using. So this is a hard one for people to swallow, but it happens every single day. And that's talking about safety planning. So again, safety planning in another direction. Like, there are ways to reduce the risk if someone is using in the home. It's a hard conversation for anyone to swallow, right? Like, we're seeing stuff in the news and the media about babies being exposed to all these things or whatever, but it's gonna happen with or without your input. And so really making sure that we're talking about safety planning across the board, right? So depending on what interaction you have, or if you're just seeing somebody for the first time and you're only gonna see them for this shift, you can be aware of those things and have those conversations once you have relationship. Like, you don't want to walk into a room and say, hey, like, because it looks like you're assuming they're going to go use, right? But if you have the relationship and the rapport, or if you're working with them on other things, you can slide that in there. Like, so these are some things that really help when people struggle at home with a baby. You know what I mean? And like listing it off. Whether that means calling somebody else to be with your baby, making sure that someone else is just present in the home, that's not actively using and knows what's up, keeping your stuff stored up and away and locked. But the biggest thing for me has always been to make sure somebody else is there. So, because it's gonna happen. You know what I mean? We can give all the resources in the world, life sucks. It's like, it's gonna happen to somebody at some point. So just making sure that we're having those conversations, again, not with the inflection that we care what they're gonna do and that we're worried about their choices, but that we want them to get what they want, right? And so like, I will reiterate that over and over and over again. Like, I don't care, but I do care about you and that you get what you need, right? So I forget to breathe a little bit. So examples of improved family outcomes through compassionate care. So I don't know, blah, blah, blah. I'm gonna skip that. Yeah. I feel like an asshole, but I'm gonna skip that. So again, I just talked about this slide. I'm so bad at this. It's like, just put me up here and tell me what to talk about. So what we can do for pregnant people and parents who use drugs. So again, provide objective, unbiased data to support their informed choice and support them in their informed choice. All right, ask a lot of questions. Don't say one way or the other, right? They will, if you have a solid relationship, they will ask you for your opinion, right? And it just depends on your relationship. It just depends on your relationship. I always kind of lean back on, I don't care. Like, and then that's usually an opportunity for me to talk about, this is what happened to me, right? Or this is what I've seen happen to a bunch of other people, just to arm them with more information, but not tell them that they needed to do any specific thing. So encourage that, I just talked about this. CareOregon, didn't mention that one. introducing reduction of drug amounts and having those conversations, offering alternative drugs, right? This is way pre-fentanyl, and I get a lot of funny looks when I say this, but I used to tell people I would rather them use heroin when they were pregnant than use meth. Crazy, I know, but the meth was crazy back then. And placental abruption and all of the scary things that happen as a result of that, I don't know. If you've been using heroin for 10 years, you're probably not going to overdose. You could. It can happen to anybody at any time, but these are pregnant people who are smart and who are thinking about it and who are worried and careful, right? Especially with the support that they need. So that's kind of a thing. I'm not saying to do that. I'm not saying to say that to people in this modern day because fentanyl is terrifying, but offering alternative methods. So offering, if someone injects drugs, maybe talking about the other options there. Knowing how that works is important if you're gonna have those conversations, because sometimes people have only ever used IV drugs. Me. Like, it's just a thing. Like, I don't know. Like, I didn't know alternatives. But yeah, all of those things. There's so many things that we can do to help support people in their journey that's not telling them to quit or go to detox. We can say, these are your options, but there are other options there, and people need to hear them. And in my experience, more people choose the go to detox button or one of those buttons when you give them the full range and you give them an opportunity to try them, right? Like, I've been clean a lot of times, but there was always the thing like, well, maybe I can just snort cocaine, right? Like, maybe. And that would eat at me, and I would think about that forever until I did it, and ended up right back where I started. So, like, supporting people through figuring out what works for them is a way to make it happen now, right? Like, maybe you can't just use on the weekends. Like, call me. You know what I mean? Like, let's talk about that. So, again, we know everything gets better when people have what they need. Oh, did I make it? So yeah, so key takeaways: harm reduction approaches lead to improved maternal and neonatal outcomes. Non-judgmental trauma-informed care fosters trust and engagement. Collaboration and advocacy are essential to system change. And just on this, you guys, so many people lose their kids and don't deserve to. I come up from a family that I was always older than everybody else, so my siblings were constantly taken away, and they were returned, which was weird, right? Because we're hustlers, you know what I mean? Like, I talk real good. Like, we can figure it out. I got that from my dad. Like, it's just what it is. But our people that we serve don't have those resources. They don't have a huge family that's all in on the game, right? And I'm not saying that they should hustle the system in that way, because it was not a great experience for us. But the reality is if you have community, you can beat them. And we can be that for people and help them find it. So here's some resources. I put up the AIM bundle that we're using as a thing. Oregon's working on one. What is an AIM bundle? AIM bundle. What happened? Oh, microphone.
It's
They're
just,
gonna put these out in their links.
yeah, it's just called, the AIM is for the Alliance for Innovation on Maternal Health. That's what that stands for. And they have a bundle on the care of pregnant and postpartum patients with substance use disorder. So we're going to be using that to implement in our hospitals in Oregon.
So the Oregon Perinatal Association is going to be updated soon. Project Nurture Access. I just posted one of the many peer-reviewed Project Nurture articles up there. And the Academy of Perinatal Harm Reduction is ran by my very dear friends that have been doing this work for a long time, NICU nurses and the like. And they have everything on there. They have built everything down to tobacco and like cold medicine on there as resources. And there's links to all sorts of things. So with that, I'm gonna leave this up there. I'm not gonna say it. Y'all know how I feel. Yeah, questions? Is that what we're doing?
Amazing. Everybody, can we give a round of applause for that? That was lovely. Yeah, we've got some time for questions. We have about 13-ish minutes.
I'd be interested in hearing kind of more specifically when you were on labor and delivery, like how you initiated some of those conversations with the staff about harm reduction. I'm a labor and delivery nurse by background, and I know like we're not trained on, like that's not a background that we get. So there's probably didactic and like academic information, but some of it's just like conversation. So can you just share a little bit about how you had that conversation?
So super fun because nobody knew who I was or where I was from or why I looked the way that I looked. So for a long time, I just greased the wheels. Like I just made friends, and like I have, I don't know, I seem to have a presence about me. So like I make friends easily in community in that way. And so I would hear things all over the place and generally just like, where's that belief come from? Why? Like just ask why. Like just be annoying. Like it's just what it is. Just blah, 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 blah. I try to come at everything and everyone's beliefs with curiosity. And that actually comes from like a really genuine want to understand everything, which is kind of a broken thing in my brain, but delightful. And so just asking questions and allowing for that dialogue and then responding with kind, right? So responding in a trauma-informed way. I try not to treat anybody different than I would one of my participants or one of the people that I serve. Like it's kind of just become my entire framework for communication. And it's worked out really well. Another piece of that has been, so not for all of you guys, but has been able to call upon my lived experience. Because once people appreciate someone, know someone, like really know someone who has this story, they're more inclined to listen, right? Like inspiration porn, whatever you guys want to call it. Like I am an anomaly with all my brain stuff and everything else, but allowing people to see that and to develop relationship with the reality of the experience, even if that's just through stories. Right? So like being able to bring patient stories back to the ward. I don't know, weird word. But being able to bring those stories back and say like, you know that person? Like that person who X, Y, and Z, like they have a better job than me now. You know, and just like really utilizing like what I know from my own lived experience, the people that I serve, and curiosity, right? Like we can have opinions and bias in our work and in our personal relationships, but it's important when we're trying to help people figure out theirs that we don't hit them with it. Does that make sense? And there could be no more questions. I don't care. We can just say hi. But yeah, if there's more questions. Or feedback. I like feedback.
I work at a health system that's rolling out a new substance use screening policy and encompasses some like adult and neonatal policies. And so we're dealing with a lot of different care teams to get on board with this less stigmatized, less biased protocol. And I'm an educator in the system, and so it's I guess it's a similar question to you, but like, how do you get the buy-in of all these people in a way that's meaningful? I guess I think it's easier for us to express to the people taking care of the adults, but I'm curious about like, you said that like lactation is one of the ones that's like a little more resistant because they're thinking really about the baby as like in this single entity as opposed to it being this dyad. And then like NICUs as well, they kind of focus on the neonatal side of it. And I would love some of your like research and data on the lactation piece or like that sort of piece of it, because that's the harder part for us to penetrate somehow.
So let me email you.
Okay.
Let's meet up after this because I cannot recite all of that data right now. I'm super sweaty. But one of the big pieces of navigating all of that, in my experience, is making people connect to it.
Yeah.
So like, I'm put up on these podiums every once in a while to just like tell my story to a bunch of people up here.
Yeah.
And it's my favorite thing is making them cry, which is messed up. I'm not hurting their feelings. I'm just telling them my reality.
But you make it mean something to them.
But it means something to them, and then they connect with it, right?
Okay.
Like, I can't remember what meeting it was, but a while back I got to make some big deal person at OHP, like, cry in a small group, and like, and then suddenly be inspired to fix it, right?
Yeah.
Like, realizing what's broken. You know what I mean? And like, it feels weird and like low-key narcissistic to constantly be like, my life's been so sad. But like, it's not traumatic to me because it's my world. And I think that's another thing we need to recognize about these people. We don't typically know different or better. Like, this is just the reality that we live in. And like, honoring people's experience, but not making it a huge deal, like showing our emotional reaction to it, is huge.
Mm-hmm.
But we can give that to people who it's not their experience, right? Like, I have been written up for triggering people and traumatizing people when I was working with sex workers and stuff, and like, I don't care. Like, oh man, you have feelings because you realize what it means to be a person. You know what I mean? But like, that's been the way to, sorry, that came out weird. But that's been a way to really like get people to connect to the work and to feel like it matters, right? Because I'm up here now. You know what I mean? Like, I'm up here now doing this. People ask me to do this. And so I'm not, in their minds, I'm not the same until they hear that story.
Yeah.
Right? Like, the whole thing. I don't think that helps you a whole lot, but I'll get your contact information and I'll send you some resources.
Yeah, it's interesting to hear how you approach it and inspire people. I think that's helpful to me. Thank you.
That's really weird.
All right. I don't want to speak in a microphone, but I will. I guess I have sort of a scenario and then a request for advice on how to bring up a subject that may or may not show my bias, when I also feel like I also sometimes have a responsibility to educate. I'm not sure. So anyway, a patient with a 6-month-old that I'm building rapport with.
What's your role?
A nurse at a substance use treatment clinic. And we're chatting, and she pulls out a bottle and fills it with Gatorade and then hands it to her baby. And we keep on chatting, and I don't say anything, but I mentioned it later to the other nurses, like, oh gosh, patient was giving her 6-month-old Gatorade, oh. And they were like, you didn't say anything? And I said, no, I didn't say anything. It wasn't the right time. And I end up in this situation a lot where I wonder where my knowledge about a situation intersects with my bias and intersects with my need to educate. Yeah. And if you would have approached it differently, said something or not, and what you would have said.
Okay, so I would have went and done all the research that I could and figure out what exactly the implications are of that, which we know things, right? Like, we know things, we've learned things, we know what is good and what is not good for a baby's development and everything else. But I would be armed with a bunch of information and be like, hey, I was super curious about this, like, and like, I wondered, because I know that's not something we typically suggest or whatever, so I did this research. And I would just share it that way. If you have a relationship with them, like, that's what I would do. Like, hey, like, we typically, like, frown on that, but I wasn't sure, so I went, because it shows that you invested time and energy.
That's great.
Does that make sense?
Yeah, definitely.
I mean, that's an opportunity to build further rapport. Be like, I didn't know, I just know that like, typically we only say milk and formula or whatever. But I went and looked it up because I know you want to be a great mom or whatever, you know. Don't say that. But like I know you know what I mean? Like, I know, whatever. You know what I mean.
Yeah, awesome. That's a really good idea. Thank you.
That's not bias, that's science.
That needs to be a bumper sticker.
Thanks so much, Kasey. I always enjoy hearing you speak, and I always appreciate your thoughts and perspective and knowledge and experience. I'm trying to formulate a question here, so forgive me if it's not the most eloquent, but so I'm a nurse with OHSU and have worked with Project Nurture for almost a decade. I feel very well versed in providing a harm reduction approach and education and resources for folks who are using substances, but where I feel like I lack some knowledge, and you touched on it some, is harm reduction for children when there's substance use in the house. And I'm wondering if there's any like accessible patient education materials or websites or places that you point parents to when they're looking to provide harm reduction when there's substance use in the house with children.
So yes and no. I typically don't point people to the internet, and I try and bring them the things, just because we know what Googling things does, and if we start that, you know. But I have had people that are super open to it. So I tend to send everybody to the Academy of Perinatal Harm Reduction Toolkit. We were working on an organ-specific one, because that's just like broad spectrum, pulling out a lot of information from, I think, New York. But we were working on an organ-specific one. I don't know what happened with that, but the data is the same. Like the information is there. That is the same, and there's just so much there. Is that your question?
Yeah, more or less. What I would love to be in existence, and I don't think is just like a one-page, like really patient-friendly flyer of like, here's some steps you can take if you have children.
They do have flyers.
They do?
They do
Okay.
have printable one-pagers and stuff.
Awesome.
If what you are looking for is not there, let me know,
Okay.
because I'm sure we have it in the back pocket somewhere.
Cool, will do.
Yeah.
Thank you.
And then, did you have a question, Tracy? Okay. Any last? We have about two Tracys next to each other. I love that. Awesome. Any other last minute thoughts, questions? Oh my gosh, that was fabulous. Another round of applause.